Our next presentation is called Direct Thrombin Inhibitors Partially Reduce the Negative Effects of Heparin on Lung Growth and Function After Murine Left Pneumonectomy, being presented by Dr. Savas Tzikis.
Congenital diaphragmatic hernia, or CDH, occurs with an incidence of 1 to 4 cases per 10,000 live births. Infants with CDH are frequently born with severe bilateral pulmonary hypertension, bilateral pulmonary hypoplasia, pulmonary hypertension, and cardiac dysfunction. The cardiopulmonary disturbances can be so severe that infants require extracorporeal membrane oxygenation, or ECMO, for their survival. While on ECMO, and to maintain circuit patency, systemic anticoagulation is necessary, with heparin being the most common choice of anticoagulant used in this setting. The direct thrombin inhibitors, abbreviated as DTIs, bivalirudin and argatroban, are alternatives for this indication. Survival on ECMO, in part, is a race against time for lung growth and regeneration to occur as mortality increases with longer ECMO durations. Our lab employs a CDH model of compensatory lung growth, or CLG. In this model, mice are anesthetized, intubated, and the left lung is removed via left thoracotomy and hilar ligation. The remaining right lung is left in situ, and its growth is studied postoperatively. In this model, we recently demonstrated that continuous administration of heparin impaired lung growth, alveolarization, vascularization, and exercise performance. The direct thrombin inhibitors bivalirudin and argatroban, however, did not impact these key outcomes, which supports their use in CDH patients on ECMO who depend on expeditious lung growth for their survival. While DTIs are increasingly used clinically in ECMO circuits, infants may still simultaneously receive heparin, either in low-dose or high-dose configurations. To investigate the effect of mixing low-dose heparin with DTIs on lung growth, in vitro experiments were first performed. In these experiments, human lung endothelial cell proliferation and apoptosis were assessed following treatment with low-dose heparin alone or mixed with increasing concentration of DTIs. Based on these results, heparin alone significantly decreased endothelial cell proliferation and increased cell apoptosis, consistent with its known anti-angiogenic effects. The addition of increasing concentration of either bivalirudin or argatroban reversed the negative effect of heparin on cell proliferation, but had little impact on apoptosis. Based on these results, we hypothesized that therapeutic anticoagulation with bivalirudin or argatroban mixed with low-dose subtherapeutic heparin will partially rescue lung growth in vivo. To evaluate this hypothesis, C57 Black 6J mice underwent left pneumonectomy and subcutaneous implantation of osmotic pumps, which allowed for continuous anticoagulation of DTIs to be achieved. Treated animals also received daily injection of low-dose heparin. In total, 4 groups were studied: a control group that received normal saline throughout, a heparin-only group which received the daily IP injection of low-dose heparin, and 2 mixed anticoagulated groups, where in addition to daily low-dose heparin, mice were continuously and therapeutically anticoagulated via osmotic pump with either bivalirudin or argatroban. The dosing regimens were based on prior experimentation and confirmed again in this experiment through PTT measurement. All outcomes were assessed at postoperative day 8, as this is the time point at which CLG is known to be complete. Lung growth was assessed by lung volume measurement through the water displacement method. Heparin-only treated mice demonstrated significantly decreased lung volume compared to saline-treated controls. The mixed bivalirudin and argatroban groups, however, had preserved lung volume based on this metric and the lack of a significant difference to the saline-treated controls. Lung function was assessed through pulmonary function testing. Lung function was decreased across all 3 heparin-exposed groups, as measured by the inspiratory capacity and total lung capacity, key metrics of pulmonary function testing in mice. To further characterize the differential impact of mixed anticoagulation on lung growth compared to lung function, morphometric analysis of stained lung sections was performed by a master observer based on the principles of stereology. Based on this analysis, all 3 heparin-exposed groups had decreased lung alveolarization as a composite outcome of parenchymal volume, alveolar volume, and alveolar density. This finding is further corroborated by representative hematoxylin and eosin stained lung sections in panel D compared to the controls. Lung vascularization was assessed by immunostaining for the endothelial cell marker CD31. CD31 staining, which is represented by green in the screen, was decreased across all 3 heparin-exposed groups compared to controls, as demonstrated by representative immunofluorescence slides in panel A and the quantified analysis of signal intensity in panel B. To determine if all of these findings correlated with a physiologically relevant outcome, A separate cohort of mice underwent treadmill exercise tolerance testing prior to surgery, followed by repeat testing prior to euthanasia, and the percent change in exercise performance was calculated. In this experiment, heparin, with or without DTIs, reduced exercise performance, as measured by the percent change in distance run and time spent running, compared to saline-treated controls. In conclusion, heparin, even at low doses, inhibits lung growth and function in the CLG model. The DTIs do not impact these key outcomes. Addition of DTIs to low-dose heparin partially rescues the inhibitory effects on lung growth, but fails to reverse the effects on lung function, alveolarization, vascularization, and exercise performance. Based on this data, the concomitant use of low-dose heparin with DTIs should be carefully re-examined. Ultimately, however, clinical studies on the impact of low-dose heparin with or without DTIs on CD8's outcomes are warranted. I would like to thank our study team, acknowledge our funding sources, and I would be happy to take any questions.
This presentation is open for discussion.
Augusto Zani from CKIDS Toronto. Thank you very much for this beautiful presentation and really compelling data. I'm wondering about the mechanism behind and whether you had a chance to look into that.
No, that's a great, thank you. That's a great question. I didn't have time to go over it in these slides, but we did do bulk, sorry. We performed.
It's not arranged.
We performed bulk RNA sequencing of lung tissue to further characterize the mechanism whereby low-dose heparin exerts effects on lung growth. And based on ingenuity pathway analysis, we saw broad downregulation of key canonical growth factor pathways across the board that are implicated in lung growth, alveolarization, vascularization, resulting in a predicted increase in pulmonary hypoplasia. We've also done protein works and Western immunoblotting to characterize activation of key receptors and have demonstrated decreased activation of receptors such as VEGFR2, which is a key receptor in angiogenesis and growth.
Great stuff. Thank you.
This is really great work, and in the ECMO community, there's a lot of discussion about whether or not we should be switching from heparin to DTIs, and it's really exciting to see this work because I think it's going to be very helpful in that discussion. No question, just a compliment. Any other questions? Thank you.